Okay. Thank you very much for your introduction. I'm very happy to introduce Dr. Tanaka. He made the concept of the pelvic ring instability syndrome in Japan. I respect his great works. Tonight, we have a legend, Dr. Hirokazu Tanaka, in this webinar. I hope, Dr. Tanaka, would you give us some comments?
Hello, I am Tanaka. Now investigated.
Introduce.
Mm,
Introduce.
Introduce uh, today. I'm happy to share my thinking of uh, pelvic ring instability today. Thank you. いいかな?
It's great honor for me to be invited to today's. Thank you.
Okay. Thank you for nice comments. So I'd like to share my screen. Uh, okay, I would like to talk about diagnosis and treatment of pelvic ring instability syndrome based on Dr. Tanaka's perspective first. Then I would like to share the Japanese cases who delivered after sacroiliac joint fusion surgery. This picture shows the only Japanese dessert and very famous place of sightseeing in Tottori Prefecture. It is hometown of Dr. Tanaka. In Tottori, there is a sand museum, which is rare in the world. It is very surprising that they are all made of sand. It is known as the birthplace of the creator of Conan, a very popular Japanese animation. English title is Case Closed. Again, Dr. Hirokazu Tanaka is a Japanese orthopedic surgeon who first created the concept of pelvic ring instability syndrome in the 1980s. I thought he was no longer active, but he published a new paper in 2023, and I was very happy to meet him in person. Japan has two legends, Dr. Tanaka and my mentor, Dr. Murakami. Interestingly, both of them pioneered sacroiliac joint or SIJ injections, but Dr. Tanaka went on to fix the pubic symphysis, and Dr. Murakami went on to fix the SI joint. Dr. Tanaka's daughter, Dr. Suda, sent me a picture of young Dr. Tanaka, and I was very surprised to see that he looked as nice and cool as a Japanese movie star. As you all know, left and right sacroiliac joints work together and function best. For this purpose, the stable pubic symphysis is important. This is a paper on pelvic instability written by Dr. Coventry of the Mayo Clinic. When Dr. Tanaka was thinking about pelvic ring instability, he found this paper very helpful. In this patient, bone was harvested from the left posterior superior iliac spine for L4-5 fusion. The SIJ posterior ligament was injured, so the SIJ loosened, resulting in upward dislocation of the left pubic symphysis. As you know, the dislocation of this SI joint itself is difficult to assess radiographically, but is reflected in the displaced pubic symphysis like this. Based on the evidence of these surgical procedure results, Dr. Tanaka constructed his theory. When an abnormal force is applied to the SI joint, the force is counteracted by the pubic symphysis, which are far from the SI joint. By the principle of leverage, the strong force applied to the SI joint can be controlled by the pubic symphysis, even though the counter force is weak. If this balance is lost, the pelvic ring becomes unstable and repeatedly strained at this joint, this junction, sacroiliac joint. Dr. Tanaka made the criteria for diagnosing pelvic ring instability in 1981. The first item is pain at the lumbosacral region and/or the pubic symphysis. The pain area is most often in the SI joint area. Surprisingly, subjective pain in the pubic symphysis is less common. The examination procedure includes tenderness at the SI joint and pubic symphysis. Various pelvic ring stress tests are performed to see if complaints increase. Okay. Pubic symphysis compression test, distraction test, or Newton test type 1, Patrick test are often used. And hip hyperextension test is performed and tenderness of the SIJ regions are examined. These pelvic stress tests showed high positive percentage in patients with pelvic instability syndrome. Interestingly, the patient may complain of pain in the SIJ area during the straight leg raising test, but the pain is more intense when the raised leg is suddenly dropped. A clicking sound may also be heard. Finally, the diagnosis is done by using local anesthetic injection to posterior sacroiliac ligaments or to the pubic symphysis. In the image, more than 2 millimeters of slip motion between the pubic rami on X-ray with one leg standing is a positive sign. As you can see, right side of pubic rami slips cranially when the patient stands on right extremity. This is a study that cannot be done today, but in normal women, the pubic rami does not slip more than 2 millimeters. This is a case of pelvic ring instability syndrome. Following Dr. Tanaka's technique, we ask a patient to stand on one leg in this manner and take image the level of pubic bone. Characteristic radiograph images include abnormal mobility between both pubic rami, osteitis pubis, and osteitis condensans ili at the SI joint. Among these, osteitis condensans ili is observed in 16 out of 116 cases, or 14%. All of the patients were women, even without pregnancy and childbirth. Pelvic ring instability is caused by hormonal influences in women who are in a state of preparation for pregnancy. Learning this was a significant turning point in my practice because I have believed that this problem only occurred in the postpartum period. This is a pelvic orthosis designed by Dr. Tanaka. Regarding treatment outcomes, he found that the effect of the sacroiliac joint injection to the posterior ligament has diagnostic value, but the benefit was temporary in women patients classified as having pelvic instability. Therefore, he focused on treatment with a pelvic orthosis. Radiographically, the orthosis reduced the abnormal mobility of the pubic symphysis. This is a new functional pelvic orthosis. Dr. Tanaka kept thinking of a better one. Finally, he obtained a patent for this belt. In this way, the pubic band supports the entire pelvic ring. The angle of this band attachment is also important. The band is not intended to compress the pelvis, but rather to hook from the head side of the iliac crest and pull downwards. Dr. Tanaka has in his mentor, Professor Ryohei Suzuki, first introduced the lumen bugle method in Japan and introduced the theory of congenital hip dislocation repair. In the same way, for pelvic ring instability, gradually guide the pelvic ring into a good position while moving it and wait for fiber stabilization. This was the origin of the idea for the functional pelvic orthosis. This slide shows the latest clinical outcome of functional pelvic orthosis. In this case series, there are many patients with pelvic ring instability syndrome triggered by standing, heavy lifting, obesity, and sports activity, rather than postpartum patients. In all cases, symptoms were relieved and the patient were able to return to their usual life. Wearing the belt reduced the frequency of SI joint injections. In most cases, the belt can be removed after about 3 months of wear, but in some cases, it may take 6 months to a year. If discomfort returned after the belt is removed, or if the patient strains at work or with housework, the belt should be reapplied to prevent recurrence. Dr. Tanaka also did anatomical studies. The SI joint move more easily when the pubic symphysis is cut than when the periarticular SI joint ligaments on one side are separated. So, conversely, immobilization and unstable pubic symphysis contribute to sacroiliac joint stability. Most cases of pelvic ring instability syndrome show abnormal mobility of one side of the SIJ and pubic symphysis. In addition to the intact side of the SIJ, pubic symphysis fixation alone would result that 2 of the 3 points in pelvic ring would be stable. It would be sufficient for pelvic ring instability treatment. Based on this theory, Dr. Tanaka performed pubic symphysis fusion surgery using tension band technique with bone grafting. At the time, he operated on 6 cases, 5 of which had good results, although one case required revision surgery because the Kirshner wire was broken. He noticed that some patients had hypoplastic pubic bones. Other surgeons reported pubic symphysis fixation as well. Pubic symphysis fixation was often performed together with SI joint arthrodesis. 6 of 8 patients showed good surgical results. Swedish surgeons reported that pubic pain was relieved in all cases after arthrodesis involving pubic symphysis, but SI joint pain persisted in 4 of 8 cases. I'd like to summarize. Pelvic ring instability syndrome occurs even when not related to pregnancy and childbirth. Displacement of the pubic symphysis more than 2 mm in one leg standing position is abnormal. A pelvic orthosis can hold the pubic symphysis and functionally stabilize the pelvic ring. Fixation of the pubic symphysis alone occasionally reduces pain in both the pubic symphysis and the SI joint. In the international literature, fixation of the pubic symphysis alone was rare, and the SI joint was often fixed at the same time. I'm extremely grateful to Dr. Tanaka. Learning from him has given me a deeper understanding of the pathology of women in this age group and more treatment options. This is our case. 26-year-old woman was injured when she bent forward and twisted her trunk while walking. There is also tenderness in the pubic region and SI joint pain on the left side. Conversely, the left side of the pubic lamp is down. Thus, the patient had severe gait disturbance. Treatment continues with prolotherapy and pelvic orthosis. Wearing the functional pelvic orthosis has improved walking and the ability to ascend and descend stairs. Functional pelvic orthosis is very effective for this patient. Much different between with orthosis, without orthosis. 34-year-old woman complains of buttock pain and feeling of pelvic instability after the first birth. She was having a difficult time with suspected mental illness, including depression and somatoform disorders. Her left pubic lamina showed slip motion to cranial. Prolotherapy and transversus abdominis muscle training with functional pelvic orthosis were very effective. After 4 months treatment, now she is able to get up and be active all day. The last section describes cases of delivery after sacroiliac joint fusion surgery in Japan. 38-year-old woman was not able to get pregnant due to severe left side of SI joint pain before surgery. She got pregnant after left anterior SI joint arthrodesis and gave birth by cesarean section. Her life changed dramatically. I'd like to introduce a special spine surgeon, Dr. Satoshi Makio. He performed SI joint fusion surgeries, and as a result, 3 new children were born. It helped to reduce the declining birth rate in Japan. 26-year-old physical therapist suffered from severe low back pain and short sitting tolerance only 2 minutes. Dr. Makio performed left SIJ arthrodesis. Then she got pregnant at 9 months after the surgery. She complained of pubic symphysis pain for late pregnancy period. She gave birth by cesarean section and pain at left SI joint and pubic symphysis disappeared after delivery. Later, she gave birth her second child. The same process was followed. 24-year-old woman showed severe left SIJ pain. She got pregnant 1 year and 3 months after left SIJ arthrodesis. She gave birth by cesarean section as well. All patients who underwent SI joint fusion in Japan were recommended to have a cesarean section. A natural childbirth was considered to have high risk because of the fused SI joint. Interestingly, in other countries, natural birth is not a problem. I'd like to learn a lot from Dr. Ben Strossen and Dr. John Stark about these issues. By the way, we know that pelvic floor muscle is important to stabilize the sacroiliac joint. We verified with Android model, aiding structure to mimic pelvic floor muscle. In Android model, we observed that the sacrum was stabilized and gait improved. So we realized that pelvic floor muscle is important for human bipedal walking as well. Coxalgia, pelvic floor muscle dysfunction are missing pieces in our orthopedic practice for pelvic problems, including the sacroiliac joint. Women PTs in Japan are conducting academic activities and providing a high level of physical therapy. I will learn from them a lot to understand the sacroiliac joint deeper. Now, Dr. Tanaka has 3 questions for the international experts. I admire Dr. Tanaka's never-ending passions. Question 1, is early postpartum walking really a good idea? Is working with ligament laxity a risk of pelvic instability syndrome? Question 2. Why is postpartum sacral joint laxity more likely to be unilateral? Question 3. In order to stabilize the pubic symphysis, it may be effective to increase the strength of the linear alba attached to the superior border of the pubic symphysis. For this purpose, is it effective to strengthen the rectus abdominis and internal external oblique abdominal muscle as a treatment to increase the force of the linear alba? Does anyone have answers? I will copy them into the chat section, so if anyone has answers during this webinar, please write and share with us. Thank you for your attention.
Great, thank you. Excellent presentation and very interesting history and interesting work. In the benefit of time, I will ask everyone to keep their questions for now until the end. And you're welcome to put the questions in the chat message as well. And we will have a discussion at the end of the presentations. As such, I will invite Dr. Moreno to start and share her screen and start the presentation. Thank you.
Okay, thank you.